Hello everyone, my name's Steve. I'm talking to you from Webster University in St. Louis. I'm a student in the CRNA program here. And today we're going to be talking about cricothyrotomy, or surgical airway access, that hopefully you never do, but if you have to, I want you to have the tools necessary and the knowledge necessary to do it right and help save a life. So essentially the indication for this is cannot intubate, cannot oxygenate, and that's it. You've worked your way through the airway algorithm and gotten to the point where there's no other option but doing surgical access to save this patient's life. So we've exhausted all of our steps and adjuncts, and this patient is gonna die if we don't do this, so we need to jump on it quick. You're gonna, if you have access to cleaning supply, as best you can before you make an incision. Then you're going to palpate. You find your landmarks. You have your thyroid cartilage and your cricoid cartilage. In between there is going to be your cricothyroid membrane. Once you find those two spots, you're just going to make a vertical incision in the neck, 3 to 5 centimeters long. This gives you plenty of view to find the membrane, which at this point there's going to be blood, so you're going to be feeling for the membrane more than you're looking for the membrane. Once you found it, you're going to take your scalpel and you're going to make a vertical incision through that membrane, and you're going to put your finger into that spot to maintain the airway. Next, what we're going to be covering is doing this technique as a modified Saldinger technique with a bougie. Bougie goes into the airway through the cricothyroid membrane, and this is going to secure your airway opening. Then next, you're going to slide your tube over the bougie, and this will direct you straight into the airway, no question about placement. Once your tube is in place, you're going to inflate the cuff, and you're going to begin ventilating your patient. You're going to note chest rise immediately once you start ventilating. If you have the capabilities of checking end-tidal CO2, you can also use that to confirm placement. But essentially, you've gone through the steps, you've visualized the area, you've made an incision directly into the airway, you're in the airway. So you're going to continue to ventilate until you stabilize your patient. So keys with this: once you have them stabilized, oxygenated, ventilated, hook them up to your ventilator if you have a ventilator. If you don't, you're just going to continue bagging them. You can have somebody take over that while you tape, but you want to secure this airway. It's definitely not something that you want to lose after you've saved their life. This is adequate airway, but it is not a permanent airway. This patient will eventually have to have a tracheostomy unless this was, an allergic reaction or something like that that's quickly reversible. May be able to just take this out later on down the road. But that's it. Running through those steps multiple times and just practicing this on your own is recommended. So when the time comes, if you have to do it, you're not really thinking about it. You're just going through the motions that you've done enough to where it's just muscle memory. Again, I hope you never have to do this, but if you do, I hope this video helps, and I look forward to seeing you guys in May.